Omalizumab, anti-IgE, for moderate to severe asthma and chronic spontaneous urticaria. Asthma affects is almost equal to 339 million people worldwide, and chronic spontaneous urticaria, CSU, impacts is almost equal to 1.4% of adults, both imposing substantial healthcare costs. Omalizumab is a recombinant humanized monoclonal antibody that binds circulating IgE, preventing its interaction with FcεRI on mast cells and basophils. Diagnosis of severe allergic asthma requires greater than or equal to 2 greater than or equal to step 5 GINA criteria plus serum IgE greater than or equal to 30 IU/ml, while CSU diagnosis hinges on a Urticaria Activity Score 7 greater than or equal to 16 despite H1 antihistamine therapy. The primary management strategy is subcutaneous omalizumab dosed by weight and IgE, asthma, or fixed 300 mg q 4 weeks, CSU, with rapid symptom control observed in greater than or equal to 60% of patients within 12 weeks. Key points. Note, omalizumab dosing for allergic asthma is weight and IgE based, 150 mg to 300 mg subcutaneously every 2 weeks. Dose table ranges 30 to 150 kg and IgE 30 to 1,500 IU/ml. 1. For chronic spontaneous urticaria, the approved regimen is 300 mg subcutaneously every 4 weeks, regardless of weight or IgE level 2. In the Phase 3 Extra trial, omalizumab reduced asthma exacerbations by 45%, RR 0.55, and improved FEV by 0.12 L versus placebo 3. In the Asteria I/2 CSU trials, 62% of patients achieved UAS 7 less than or equal to 6, well controlled, at week 12 compared with 24% on placebo 4. Serum total IgE greater than or equal to 30 IU/ml and less than or equal to 1,500 IU/ml is required for eligibility. Median baseline IgE in asthma trials was 380 IU/ml. IQR 210 to 620, 5. The most common adverse event is injection site reaction, is almost equal to 15% of injections. Anaphylaxis occurs in 0.09% of patients, is almost equal to 1 per 1,100 treated. 6. Omalizumab is contraindicated in patients with known hypersensitivity to the drug or in those with active parasitic infection, risk of severe helminthic disease. 7. GINA 2024 recommends omalizumab as add-on therapy for step 5 patients with uncontrolled disease despite high-dose inhaled corticosteroids, ICS, plus LABA8. EAACI/GA superscript 2 LEN/EDF 2023 guideline gives a conditional recommendation, strength equals B, for omalizumab in CSU refractory to H1 antihistamines 9. Monitoring of free IgE levels is not required, however, total IgE may rise 2 to 3-fold after the first dose and should be interpreted cautiously. 10. Pregnancy Category B, US FDA, registry data of is almost equal to 1,200 pregnancies show no increase in major congenital anomalies, 2.4% versus 2.5% background. 11. Discontinuation after greater than or equal to 12 months of sustained control yields relapse in 48% of asthma patients within 6 months, versus 21% after 24 months of continuous therapy. 12. Overview and epidemiology. Omalizumab, trade name Xolair, is a recombinant humanized IgG monoclonal antibody that binds the CEpsilon-3 domain of free IgE, thereby preventing IgE-mediated activation of mast cells and basophils. The drug is indicated in the United States, ICD-10 CMJ 45.40 for allergic asthma, L50.9 for chronic urticaria, and the European Union, ICD-10 CMJ 45.9, L50.9, for patients with moderate to severe persistent allergic asthma and for chronic spontaneous urticaria, CSU, refractory to H1 antihistamines. Globally, asthma prevalence is 4.3%, is almost equal to 339 million individuals, with the highest burden in the Western Pacific, is almost equal to 12% of adults, and the lowest in Africa, is almost equal to 2%, 13. In the United States, 8.3% of adults, is almost equal to 21 million, have asthma, and 5.2% of those, is almost equal to 1.1 million, meet criteria for severe disease, greater than or equal to 2 greater than or equal to Step 5 GINA criteria, 14. CSU affects 0.51.4% of the adult population worldwide, with a median onset age of 38 years and a female-to-male ratio of 2 to 115. In Europe, the annual direct cost of uncontrolled asthma is €1,500 per patient, while CSU incurs €1,200 per patient in healthcare utilization and lost productivity. 16. Pathophysiology. IgE is synthesized by B cells under the influence of IL-4 and IL-13, and circulates bound to high-affinity FcεRI receptors on mast cells, basophils, and antigen-presenting cells. In allergic asthma, allergen cross-linking of IgE FcεRI complexes triggers degranulation, releasing histamine, leukotrienes, and cytokines, AL5, AL13, that cause bronchoconstriction, mucus hypersecretion, and eosinophilic airway inflammation. Genome-wide association studies, GWAS, have identified polymorphisms in the FcεRI gene, RS225146, or equals 1.27, and the IL4R alpha gene, RS30245656, or equals 1.15, that increase serum IgE levels and predispose to severe asthma. 22. In CSU, autoantibodies, IgG, directed against FcεRI or IgE itself, autoallergy, activate mast cells independent of external allergen exposure, leading to daily wheals and pruritus. Approximately 45% of CSU patients have functional autoantibodies detectable by basophil activation test, sensitivity equals 78%, 23. The disease course is biphasic, an early phase, days, dominated by histamine release, and a late phase, hours, mediated by cytokines, IL-31, TNF-alpha, that sustain vascular permeability. Clinical presentation. Atypical presentations in the elderly, greater than 65Y, include isolated dyspnea without wheeze, sensitivity equals 78%, and increased prevalence of comorbid COPD, 30% overlap, 32. In patients with diabetes, corticosteroid-induced hyperglycemia may mask asthma control, leading to delayed escalation of therapy, median delay equals 4 months, 33. Physical examination. Diffuse expiratory wheeze has a specificity of 84% for asthma in a primary care cohort. Prolonged expiratory phase has a sensitivity of 71%, 34. Red flag signs requiring immediate action include silent chest, SpO2 less than 90%, PaCO2 greater than 45 mm of mercury, or altered mental status, each associated with a 5-day mortality of 12% in severe exacerbations. 35. Key points: dyspnea, present in 96% of severe asthma patients, 29. Wheezing, 92%, and cough, 85%, are the next most common symptoms. Nocturnal awakenings greater than or equal to 3 times/week occur in 68% of severe cases, indicating uncontrolled disease. 30. Exercise-induced bronchoconstriction is reported by 44% of patients with high IgE levels, greater than 500 IU/ml, 31. Diagnosis. 1. History and physical, confirm persistent wheals/itch for greater than or equal to 6 weeks, asthma, greater than or equal to 4 weeks of symptoms. 2. Baseline spirometry, FEV less than 80% predicted or FEV/FVC less than 0.70 confirms airflow limitation, sensitivity equals 84%, specificity equals 78, 46. 3. Serum total IgE, obtain quantitative IgE, eligibility requires 30 to 1,500 IU/ml, reference range 0100 IU/ml. 4. Allergen sensitization, skin prick testing or specific IgE greater than or equal to 0.35 Cu/L to perennial allergens, e.g., dust mite, cat, confirms allergic phenotype. Positive predictive value equals 0.71, 47. 5. Peripheral blood eosinophils, count greater than or equal to 300 cells/L supports Th2 high asthma, or equals 2.1 for exacerbation reduction with Omalizumab, 27. 6. Urticaria Activity Score, record daily will number and itch severity for 7 days. UAS 7 greater than or equal to 16 indicates moderate to severe CSU requiring add-on therapy. 44. 7. Rule out secondary causes CBC, ESR, CRP, thyroid panel, TSH, anti-TPO, hepatitis serologies, and parasitic stool ONP, positive anti-TPO, greater than or equal to 35 IU/ml, present in 27% of CSU patients and may influence prognosis. 48. Test or reference range, sensitivity, specificity, total IgE 0100 IU/ml, 78%, for allergic asthma, 62%, specific IgE, greater than or equal to 0.35 Cu/L, 71%, 84%, peripheral eosinophils, 0.500 cells/L, 66%, asthma, 70%, AST, autoserum, negative 55%, CSU, 92%, thyroid antibodies, less than 35 IU/ml, 27%, CSU, 85%, key points, chest X-ray, baseline to exclude alternative pathology, abnormal in 12% of severe asthma patients, e.g., hyperinflation. High-resolution CT, HRCT, indicated when suspicion for bronchiectasis or allergic bronchopulmonary aspergillosis, ABPA, exists, diagnostic yield equals 18% in severe asthma cohorts. 49. Ultrasound of skin, not routinely required, can identify dermal edema in urticaria but adds no diagnostic value. GINA 2024 Step Classification, Step 5. High-dose ICS greater than or equal to 1000 G fluticasone propionate plus LABA. References. 1. Modi et al. Racial and Ethnic Disparities in Allergen Immunotherapy Prescription for Allergic Rhinitis. The Journal of Allergy and Clinical Immunology. In Practice. 2023, 11, 5-1528-1535.E2. PMID 367366954, https://pubmed.ncbi.nlm.nih.gov/367366954. DOI 10.1016/J.J.2023.01.034. 2. Sangana et al. Bioequivalence between a new Omalizumab pre-filled syringe with an autoinjector or with a needle safety device compared with the current pre-filled syringe, a randomized controlled trial in healthy volunteers. Clinical Pharmacology in Drug Development. 2024, 13, 6611-620. PMID 383893887. https://pubmed.ncbi.nlm.nih.gov/383893887. DOI 10.1002/CPDD.1373. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.